On my left, starting on my left is Dr. Mike Demetria. Mike is actually a physician with Cook County Stroger Hospital and a hepatologist, and he sees patients mono-infected and co-infected for hepatitis B, C, and HIV. Next to him is Derry Min. Derry is the executive director of the Cambodian Association of Illinois. Esther Wong, who is the executive director of the Chinese American Service League. Dr. Fong Tran, who runs a private practice and sees a lot of patients, hepatitis patients in Uptown, which is one of Chicago's most underserved neighborhoods, and she's former faculty from the University of Chicago. And finally, Inchol Choi, who's the executive director of the Korean American Community Services. Thank you all for your participation.
Thank you, Edwin. I feel like I'm Phil Donahue or Oprah Winfrey with this walking microphone. So I know we have a really great panel of providers and also community-based organizations. So what I'm going to do is try to switch off and ask a question to the whole panel, and you just please feel free to jump in as needed. So my first question is, so primary care physicians are often the point of entry into the U.S. healthcare system, and therefore they are in a unique position to identify individuals at risk and provide screening and referrals to specialists. So we've heard from communities about the barriers they face. What are some of the barriers providers face when working with immigrant and refugee groups?
I guess I'll start. Just to clarify, I'm a gastroenterologist with special interest in treating hepatitis B and C. I work at Stroger Hospital. The community-based organizations are the ones who faces first the barriers that are patient-specific. And thank for them, they're the front runners, and they tend to alleviate or diminish those barriers already when we see them. As a provider, I'm a gastroenterologist. They refer those patients to us. One of the probably most important barrier that I see that affects the patients that affects our clinic is language barrier, okay? It has been proven that limited English proficiency occurs in up to at least 30% of Asian Americans, and even as high as 60% in certain ethnicities. And limited English proficiency have proven to diminish the availability of preventive care to these patients, and also it limits the care going into medical care for the whole family. So it is really, truly important. I see patients all the time that are Asian, and when they see me, you know, they see their faces lights up, and they said, "Oh, do you speak Chinese?" "Oh, I'm sorry," and then, you know, their faces just gets down, they feel bad. But it's their job as a provider to at least provide them with a patient-directed communication, explain to them what their disease is, and understand and have a better knowledge about the available treatments. It's a preventable disease, and eventually, with this relationship with the patient, you will have a continuity of care, which I think would start with the language barrier. And if you have a continuity of care, because even me, I miss some of these preventative care at the first visit. But as you go along and see them, you actually will recognize some of these areas that you've missed initially. So it's very important that adherence, participation of the patient, and actually starts with concordance with language, and more importantly, sometimes culturally.
Thank you, Mike. It's well said. And I just like to add that definitely in addition to the language barrier, there are other cultural factors that's also involved which influence other barriers. But I'd like to also share with you that the first one I'd like to share is about awareness and really being out there to an outreach to the community where organizations like us, the Cambodian Association of Illinois, as we all know, we all are really stretching in our capacity to do this. And we've been fortunate to have Asian Health Coalition, and others to be able to provide the means and the expertise for us to do that. But definitely, I think in terms of really doing the awareness session and doing the screening is really, really a huge factor that we need to be out there and do more. For us, I think it's also the barrier of this fear that especially among our community members, where it's such a fear of trying to find out oneself and one's own health, and trying to avoid finding out. And when one found out, one very often very reactive and very surprised, and so it's a very painful process to also do that. But I do think that, again, going back to CBOs and organization and community doing so much more outreach and just being more informed, and whether it means interpretation or translation by literature, I think gradually things will change. Thank you.
Just as a jumping point from that, Dari, I think you kind of lead on to like the next question, which is around, so hepatitis B screening rates among Asian American adults have been found to be low, and many with chronic hepatitis B infection remain asymptomatic. What are some of the risk perceptions, and I think you alluded to it a little bit, and barriers in your communities around hepatitis B education and screening? So that's open to the whole panel.
We serve mostly Chinese immigrants in the Chinatown area, and for us, the biggest barrier is the cultural barrier, because of the experience that these immigrants have back in the old country. The discrimination that they have experienced if you are identified with having hepatitis B, it affects their employment, it affects their going to school. So, and then, so when we talk about screening, Chinese are not used to preventive medicine. You don't touch it if it's not broken. So, also, if you have been, if the results come out positive in your screening, what is going to happen? The distrust of authority. What are you going to use my results for? Is it going to affect my children's education, my employment? So with these cultural experience that they have, it adds another factor to the way that we help educate them, we help them be aware of the importance of screening, of treatment. So we can't even get to the first step of having them screened.
Right. Thank
That's
you.
why, sorry. That's why right now there's a stigma, as she was mentioned. So there's a stigma among the Vietnamese patients, at least, and we have looked at that. I think we looked at it in the Chinese community, and there's a stigma, and we are currently looking at among the Vietnamese patients. So back to the beginning, when the refugees come to the U.S., there's a stigma. There's another problem is access to care. Where many years ago, 30 years ago, when we first came, there are a lot of fundings and help to help all of the refugees. Now the Asian refugees, I don't think they call refugees anymore. They come by sponsor from the family or whatever. So the resource is less than 30 years ago. So if we talk about education, screening, where's the funding is going to be for the Asian? Because I think the refugees in this 2012 is somebody else, not Asian anymore. I don't think, as I remember. So that's funding and access to care, because how we are going to educate them, how we are going to screen them, and how they are going to get into this system to be treated, if they need to be treated, and surveillance and whatever need to come after that.
Well, I think as Dr. Ward was alluding earlier this morning, even in terms of community outreach, education, and awareness, I think my community, Korean American Community Services, Korean American community is far better now than 5 years ago. And Asian Health Coalition has been doing a great job of leading these efforts. But I think it's important to establish the recognition that Agency A is a go-to agency in one field. Say, yeah, I'm a little bit, I have two distinguished colleagues here, Jun Kim and Haesun Seol from Community Health. But like, for example, if you want to do a breast and cervical screening, go to Korean American Community Services. Or if you want to do hepatitis B screening, go to Korean American Community Services. I think for CBO to establish that equation is important, and it takes time. And in terms of like other barriers that our panelists didn't touch upon, I think that uninsured and underinsured rate is a big barrier. So although you have a knowledge that you need to take 3 shots of hepatitis B vaccination, if you are not without insurance, then you may not have an access to go to physician. So that's why I think the role of CBO, giving free vaccination, is very important. And Edwin graciously is sponsoring another event with us next Friday, May 18th. And another barrier, I guess, is the sustainability of funding. Because in order to have a nurse practitioner on staff, which we do, and some medical social workers like Jun Kim and his other colleagues, we have to continuously secure funding. So that's a challenge, especially as an ED.
If I may add, Clarita.
Sure.
And we all know that these barriers eventually influence. The big factor is, really getting the message out there. Challenges. It creates challenges for us, for all of us who are in the program. And when it comes to challenges facing in hepatitis B and C, who knows better than my colleague Kairu Watanabe, Director of Holistic Health, and Sarun Seun, and Kathy, who does so much outreaching, but then see these challenges. And I think these barriers, what it does leads to is the confusion that, or the misunderstanding, perhaps more accurate, among the community members, and especially those who may already have. And so what it does, it's especially about how it is transmitted and how one can, what one can do to help maintain when one has that. So definitely, I think, again, going back to really building the capacity and really having a much more rigorous program, bringing the awareness out there, especially among women who seems to be, in our culture, seems to be the central point in the family, which is very, very crucial.
So it sounds like the access to care issues is it could be a function of being underinsured or not insured, but then the other point of that is around the availability of providers. So particularly among certain Asian subgroups, they're underrepresented in the racial composition of U.S. healthcare workforce. How does this imbalance affect accessibility to diagnostic treatment and care for hepatitis?
In reality, it should not. However, it happens. Some Asian ethnicities, I think, the availability of healthcare workforce is actually more than in general. Like Filipinos, when they see me marry Filipino, are you a nurse? That's always the first question. But true enough, there are some ethnicities where the availability of, or physician diversity is as low as 40 to 50 per 100,000, particularly Laotian, Cambodian patient population. So as a provider, I think we have to be culturally sensitive, not just taking the cultural competency training, but look into the specific needs for every community, okay? The availability of materials that are culturally and language concordant. I think those are very, very important. It's a great effort for, I think, Dr. Ward earlier showing all those informations about hepatitis in different ethnicities, but we're still lacking a lot of those in other Asian ethnicities. Even in the hospital that I work, we have tried to interpret the materials ourselves as doctors, find a doctor who speaks particular language and interpret them into that language. We're still lacking because we can only interpret some of those, but I think the encouragement and the availability of the materials like this will improve, even though there is no racial or language concordance.
So as a follow-up to that, we hear a lot about cultural competency, cultural sensitivity. From your respective areas and from your perspectives, what does that mean? So what does that mean serving your community in terms of, language access? Looks like that's one. The other one is around understanding where the patient is coming from or the community member is coming from in terms of their life experiences. So you talk about trust and what it is that they're looking to have addressed. So are there any other things that you think individuals should consider when they talk about cultural competency or cultural sensitivity, other than I took this 3-hour training in cultural competency, now I'm ready? What's the real practical, on the ground type of stuff that folks should know?
I think one of the things that is needed is translated materials in the language of the clients. And we find that it's very difficult to find funding for that. I think there's a lot of material in English or in other languages, but in order for us to educate our client, it has to be in the language that they speak. And it would be much better if it's printed out so that they can take it home and try to digest it or give it to their friends. So I think this translated material, and I know that there is not enough funding for that, so maybe that's an area that we should focus on.
I think for us, if I may take you back, the work we do, it's a lot of time has to be reflecting on our past experience and the past experience of the participants, the program participants. And for us, it's in 1975 to 1979, the Khmer Rouge took place. It was a regime that wiped out more than 2 million people in Cambodia. But what's left was much more difficult in terms of survival, because what happened during the regime was that complete trust among fellow men and among family members and among brothers and sisters, mom and children and so on, were very, very much broken down. So the family value of, again, trying to recultivate that in our community is, it has been a challenge. It's more than 30 years now, and we still continue to have that. So when our staff are out there and our staff are really leading the conversation and then bringing that conversations to the table, we have to ensure that that conversation is then eventually owned by the participant. But not only that, and be aware that it's going to take more to really pull out that conversation because of what happened in our past experience. We are a very social kind of group of people who, when we have a gathering and we have an event, we dance all night until midnight. So everybody knows everybody in the community, and that goes back kind of the sense of fear that one does not want to know. And I think that fear is really a big obstacle in the work we do in the community. But I think it's really is trying to figure out a strategy to challenge that is one way of doing it.
Right, so it seems like when you talk about strategies, what are some steps your organizations have taken and are taking to address these barriers? For example, is there work with community health workers, media, marketing campaigns, partnerships, that type of thing being done to kind of address these language needs, the needs of the community? Can you all talk a little bit about that?
Well, I think building partnership is very important, and partnership involves various layers, right? From local hospitals to, in our case, Korean language media. And every health profession has their own organization, like Korean Nurses Association, or Korean American Pharmacist Association, Korean American Dental Association. So to align all these people is very critical to the success of the program. So in our case, it has been very intra-ethnic so far, but our client base is a little bit diversifying. So we have some Latino clients coming to KACS, and I heard a couple days ago from my colleague that like a dozen Mongolians are coming to hepatitis screening day next Friday. So, Mongolians and Koreans are very much genetically related, but still it's a new client base I think we are developing. So in that sense, it's a different kind of cultural competency that we have to keep in mind for our future programming.
I think my colleagues probably can say better than I can, but I'll try to take a shot since I'm sitting here. It really is, it has certain layers in terms of trying to bring a little bit out of that, and that is, for us, we found out that certain phrase of words that we may want to avoid when we are communicating with participants and community members in terms of trying to get our message across is very important, because it could actually be interpreted negatively instead of effectively. And having the support groups and just being around to be very much allowing a very open process is very, very helpful in getting people to be very, very, very much engaging. And I know that our program, Holistic Health Program, has also the peers educators who are very, very helpful. Sometimes peer educators are doing, they're serving more than one program, which is very helpful because, again, we can then integrate the senior programs, again, with the holistic health participant as well as the youth and the children. It's just a way of seeing what is the cultural aspect and what are the things what are the strategy that you think really may work in this case.
As I said before, the Chinese experience is that if you have hepatitis B, you will be discriminated in employment. We are a multi-service social agency, so we have on our staff about 290 in-home care workers. These are people that are new immigrants that we train to do household chores and serve the frail elderly in the community. So what we have done to kind of combat this stigma that if you have hepatitis B or if you have been screened, that it will affect your employment, we built in hepatitis B education in our training programs for these in-home care workers. And they have to go through the workshop as well as the screening. And if the screening comes up positive that they needed further treatment, we refer them. So in that way, we kind of help them understand, and other workers understand that even if you have the disease or if you have been screened, that is not going to affect your employment. So little by little, we are helping, to combat this fear of screening.
So are there, so Asian American community health workers then kind of doing that in like with the Latino community, there's promotores. So is there an equivalent like that within the Asian American community, doing the outreach and education in health or more broadly?
I think that's the program that about 10 years ago, the Asian Health Coalition of Illinois have a funding to do with 5 different communities, the Ethiopian, Korean, Chinese, Lao, and Vietnamese. We screen in the community and educate the the community people. 10 or 15 years ago, we used to have that program. And we used to have a catch-up program to offer free vaccination to catch up with all of those middle-aged people that never get vaccinated for Hep B, free from the city. I don't know if that still exists, but about 15 years ago, we went and educate community workers to go into the community to teach about Hep B, and then we offer free screening, and if they are negative, we used to offer free vaccination through the city. I don't know if those, it's called catch-up program, I don't know if those still exist. Dr. Kim, do you know any about, remember that project?
Now she's calling on you,
15
see?
years ago.
Yes, I think that's right, and we're going to talk about that in one of the last sessions, but the Hepatitis B Catch-Up Program was a program that was funded by the CDC to address the needs of Asian children, or children born sort of that were not born after 1990 who had not been immunized, and so that was a really successful program. We were able to take a lot of the Chicago public schools that had kids, Asian representation over 35%, and bring their immunization rates from about 15% up to 90%. So I think that's a big program, and the HEP program is strong, alive, and well, and we'll talk about that this afternoon, but that's definitely